Okay, you've heard enough from me. Now it's time to hear from our speakers. And boy, do we have an amazingly talented bunch of presenters for you guys today. First up is Dr. Phil Choi. Many of you will know Dr. Choi as your own clinician in Canberra, as he is a consulting haematologist at both the Canberra Hospital and the National Capital Private Hospital. Now, what you may not know is that he's also the clinical director of the National Platelet Research and the Referral Centre in Canberra, and editor of the journal Platelets, and co-chair of the Scientific Subcommittee for Platelet Immunology at the ISTH. In addition to all of this work, he's also a member of the National Blood Authority Immunoglobulin Governance Specialist Working Group for Haematology, and he's on Clinical Trials Subcommittee for the Human Research and Ethics Committee in the ACT Health. Now, Phil will be talking to us today about our new treatment guidelines. These guidelines will be, he'll go through the methodology with regards to these guidelines, and he also touches a little bit on COVID-19 and the vaccines and how they've impacted ITP patients. So without further ado, Phil, over to you. Thanks, Phil.
Thanks, Danielle and ITP Australia for inviting me to speak about our new Australian guidelines for the management of ITP. First of all, why do we need these guidelines? How did we go about creating them? What were the main recommendations that came from these guidelines? And what are the future directions in the management of ITP in Australia and New Zealand? So first of all, ITP has been an area where we've always lacked high quality information with which to try to help our patients. Everything from the most basic question, like whether to use prednisone or high-dose dexamethasone, what to use if first-line treatments are unsuccessful, and moreover what to use when disease gets even more difficult to treat as the years go by. We can't even settle at the moment on the best way to diagnose ITP other than to say, well, we can't think of anything else it could be, so let's call it ITP. Of course, there have been lots of excellent international publications that have recently been updated from organisations like ASH and the International Working Group, but jurisdictions across the world differ, and access to medications as relevant to people, particularly in Australia and New Zealand, are very different to what's available in countries like the United States. The availability of special tests and investigations also varies, not just from Australia versus the rest of the world, but even within Australia, from city to city, from state to state. And of course, we really need a practical guidance that local doctors can use to treat Australians and our friends from across the Tasman with a diagnosis of ITP in a way that is easy to read and easy. So haematologists with an active interest in ITP were invited to participate in an online and virtual discussion group where we decided on the main areas of difficulty with managing ITP, looked for areas where we could find evidence and common ground. We employed a pretty standard way of describing our recommendations based on either being strong or weak, and whether there was a lot of evidence, whether there was some evidence, whether there was well-designed studies, or whether this was really just a bit of hot wind. Each recommendation was then carefully re-reviewed by all of the authors and adapted until we could all achieve consensus. Our activity was endorsed by our peak society representing doctors across Australia and New Zealand in the area of thrombosis and hemostasis. We engaged ITP Australia to ensure that we were on the right page with trying to help the group of patients that we were trying to help the most. And we've only recently published our guidelines in print version at the Medical Journal of Australia. So what were the main recommendations? Firstly, it goes without saying, as always, that ITP remains a diagnosis of exclusion, but when treatment doesn't bring about the sort of response that we usually expect in most patients with ITP, your haematologist should remain suspicious for the possibility of alternatives. We've also recommended strongly that newly diagnosed patients with ITP should start treatment when their platelet counts are consistently below 20, even if there is no bleeding. We've suggested that steroids such as prednisone should be started at a pretty strong dose of 1 milligram per kilogram. So if you weighed 50 kilograms, you'd get 50 milligrams. And that dose should continue for at least 2 weeks before we start pulling it back and hopefully finishing within 6 weeks of starting. And that's out of respect for the significant side effects that long periods of time of being on prednisone can cause. We've also, for the first time, suggested considering capping the dose of prednisone to no more than 80 milligrams a day, even for patients who weigh in excess of 80 kilograms. But this is a relatively weak recommendation. We have also suggested that dexamethasone is an equally viable alternative, and that it should be given in a 4-day course, but potentially repeated every 2, 3, even 4 weeks for up to 6 cycles. Some investigators suggest that a higher response rate can be enjoyed with using dexamethasone over prednisone. But we certainly strongly advocate using a lower dose in patients who are older. In the end, we as a panel couldn't really decide whether prednisone was any better or worse than dexamethasone, but certainly in people for whom we wish to avoid neurological or psychiatric side effects such as depression or mania, we'd prefer prednisone, whereas those patients who prefer a much quicker response, who need to get back to work or who have a busy life with kids or what have you, might prefer dexamethasone over prednisone. We also made it very clear that after first-line therapy, there should be a discussion with patients between second-line options of splenectomy, rituximab, and TPO agonists. So TPO agonists, I'll just talk about them broadly, but in Australia and New Zealand, I'm specifically referring to romiplostim and eltrombopag, and they're marketed as Nplate and Referral. And it's our strong recommendation that all 3 of these options, surgery to take out the spleen, rituximab, which is an antibody treatment to reduce your B cell population, or TPO agonists, so that's romiplostim or eltrombopag, should all be considered in second-line therapy for patients. From here, it's very much a patient preference decision. So what do you need most out of your treatment from ITP? Do you need to get back to work? Do you want to avoid side effects? Do you want a quicker response? Are you prepared to undergo surgery in order to have a higher chance of success? So, for example, patients who are younger, who've had an ITP struggle that's longer than 12 months, but certainly who have lifestyle reasons to prefer a quick solution, may well prefer splenectomy. Rituximab, alternatively, should be strongly considered in patients who want to avoid surgery at all costs, and a lot of patients fall into this category. It's also considered reasonable that if patients are a little bit younger and female, or if their disease is of a shorter duration, they're more likely to get a great response from rituximab than if they'd had disease for a lot longer, or if they were a lot older. There'd certainly be other risks to consider, particularly during this COVID pandemic. TPO agonists significantly reduce the risk of bleeding, and they are incredibly successful at being able to restore quality of life. for patients, but we know that in Australia and New Zealand it's not straightforward just writing a prescription for romiplostim or trombopag. There are regulatory hoops that we have to jump through in order to be able to get onto them. Finally, clinical trial enrollment is always a reasonable question to consider, particularly when they're available in your local hospital or wherever your haematologist is managing you. If there is a clinical trial for which you are eligible, it is an opportunity to get onto an exciting treatment that might be able to change your ITP. For pregnant patients with ITP, it's sometimes very useful to rehearse the actual delivery by undergoing some treatment for your ITP several weeks before confinement, so that if we needed to have your platelet count above 70 or 80 in order to satisfy the anaesthetist for an epidural, we'll know what works and what doesn't work. If giving you Intragam works for at least 2 weeks, then we'll know that we can give you the Intragam at the right timing just before you have induction or your delivery. It's also important to recognize that many of our patients with ITP are getting older. And as we get older, common garden variety problems become more frequent, such as heart disease and stroke, and a lot of people with ITP need to be on platelets or need treatment to reduce the risk of vascular events. We feel that drugs like aspirin and clopidogrel, which antiplatelet drugs, are reasonably safe to administer when needed, as long as platelet counts are above 30, or even both aspirin and clopidogrel could be used if platelets are above 50, particularly to avoid some of these vascular. Here's a bird's eye view for how we look at deciding between different treatments for second-line therapy in ITP. And this algorithm is based on determining whether your risk of infection or clotting is particularly prominent. So if you had a diagnosis of ITP within the last 12 months, but your ITP still needed treatment, and you'd had a history of clotting in the past, you might prefer to consider rituximab, which is a monoclonal antibody that knocks down your B cells. Alternatively, if you really have had a lot of problems with infections, particularly with steroids or in the past, and if we can justify to the PBS that you really can't go through the rigors of having your spleen removed, then a thrombopoietin receptor agonist, so that's romiplostim or trombopag, would be the options to strongly consider. And I think it's worth bearing in mind that during this COVID pandemic, the PBS have been particularly open-minded in permitting us interpreting COVID infection and the risk of COVID as being important reasons why anyone would want to avoid splenectomy. Anyone who's been diagnosed for greater than 12 months, certainly splenectomy comes into play even more strongly. But again, those who wish to avoid having their spleen removed, or if there is a surgical or medical reason we can say that splenectomy is dangerous, we could consider romiplostim or trombopag. And again, if any of you have had any clotting problems, that might sort of tip the scales a little bit towards rituximab instead. Sometimes we have to try other options until we can get our hands onto thrombopoietin receptor agonists, or until we can get an elective surgery such as a splenectomy. So other options include dapsone, mycophenolate, hydroxychloroquine, azathioprine, cyclosporin, and danazol. We present in our recommendations an algorithm for how to pick and choose between them based on how quickly we need a response. So some drugs might work a fraction faster, such as dapsone and mycophenolate. Dapsone's an antibiotic, which an old-fashioned anti-malarial antibiotic, which does actually also have some advantages in reducing the risk of pneumocystis, which is a particularly nasty infection that people who are on long courses of steroids might be susceptible to. But dapsone also does have its hang-ups. People with sulfur allergies might get a rash with it, and it can cause breathlessness as well as hemolytic anemia. Mycophenolate's another great immunosuppressive drug which has a very good side effect profile and does work very effectively for a lot of patients, but it can cause diarrhea and tummy upset and those sort of problems. Other drugs can work less quickly but may have unique advantages. So people with a coexistent history of lupus might have some benefit from using a drug like hydroxychloroquine, which could also help with, say, painful joints or arthritis. Female patients who might be thinking about starting a family soon might have some additional benefit with considering drugs like azathioprine or cyclosporin, because these are drugs that could be potentially continued throughout pregnancy. And for men who have a desire to try something that doesn't suppress the immune system, a drug like danazol, which is a hormone therapy, might also have some usefulness in people with ITP, although it's becoming increasingly difficult to get our hands on this particular drug in Australia. Your haematologist will have to put in an SAS application form to import it from overseas. When all the paperwork's done, though, it's not too difficult to use. When all the above treatments, or any of the above treatments, if they've failed to work, or if there's something not quite right about the way the platelet count isn't responding to treatment, it may be worthwhile being referred to a tertiary referral centre where there may be opportunities to consider a clinical trial if it's available, or even sequential or combination therapy with ITP. In our recommendations, we've also tried to tabulate a list of platelet counts that we think might represent a reasonable threshold for you to be able to undergo certain procedures such as minor surgery, dental extractions, lumbar punctures, gastroscopy, and so on. You'll find that a lot of the time there will continue to be uncertainty about what the safest threshold is, but at least this document will provide a reference point that your gastroenterologist or your surgeon or your anaesthetist could use to say, look, we need your ITP up to a certain level before we can proceed. So what are the future directions in ITP? Definitely there are new drugs around the corner. There are drugs that block the way your body gets rid of antibodies in a natural way, and that increases the cycling of your immunoglobulins. There are drugs that can inhibit the way your immune cells talk to each other. There are drugs that can also block the way your immune system destroys platelets. And all of these drugs in clinical trials so far have shown very promising results in subsets of patients with ITP. But how do we fit these new weapons into our armamentarium in the future? It's not really clear. We don't know which of these new drugs is better or worse to use than rituximab and thrombopoietin receptor agonists and splenectomy. We don't really understand that yet, and these are all areas of future research to understand where and how to use these new drugs. Other future directions we need to consider include how soon we should be introducing drugs like romuplastim and eltrombopag. Should they be used a little bit earlier after diagnosis of ITP rather than needing to wait until splenectomy has been unsuccessful or until someone's said that you're too unsafe to have a spleen taken out? And also there's this emerging recognition that with our inability to confidently diagnose ITP, are there patients with a low platelet count for other reasons that we're unnecessarily treating with immune suppression? So I'm thinking of patients with a congenital thrombocytopenia, in other words, people who were born with a tendency to have a low platelet count, who don't have anything wrong with their immune system. Are we hammering their immune system unnecessarily? And sometimes the only way to know is to do genetic tests. Genetics tests up until recently have been really hard to access or very expensive, but now that there's newer technology called next-gen sequencing, which is soon to be on every hospital benchtop, we may be able to do this kind of testing more routinely. Other future directions, as researchers, we need to design better studies that take in real-world scenarios. In other words, studies that don't only just recruit at the tip of the iceberg, but studies that recruit everyone or anyone with a realistic diagnosis of ITP, in order to be able to answer the questions we need to find answers to. We need to look at outcomes beyond just the platelet count itself, quality of life, bleeding, confidence, those sort of things that really impact on what you do from day to day. And also we need to know how to, or we need to incorporate ways of adapting to the world that's changing rapidly around us. Everything from COVID, the threat of COVID infection, to the threats from COVID vaccination. And we can anticipate that over the coming years there'll be updates to the guidelines. Regarding COVID vaccinations and the Australian data, out of 50 cases that have been curated across Australia of patients with ITP, about a quarter of them have been diagnosed in patients who had a previous history of ITP and who report either a worsening or a flare-up or an instability in their ITP after vaccination. About the other 3/4 of cases of ITP have been completely new. Of the patients with a prior history of ITP in Australia, about half of them have been from Pfizer, but only 2 out of those 6 were after their first dose of Pfizer. The other 4 occurred after their second dose of Pfizer. This is in contrast to patients who received AstraZeneca, where all 7 out of the 7 patients who developed a worsening of their ITP were after their first dose. These are patients whose platelet counts certainly crashed to less than 10 on median, but the great majority of them, so 12 out of 13 of patients who have a relapse of their ITP after vaccination, have a bleeding grade which is relatively modest. Some patients didn't even need any treatment or change in their treatment, and their haematologist was happy just to watch their low platelet counts with the hope that they'll slowly recover. And indeed, those who received treatment, the median time, in other words, on average, if you like, time for ITP patients to respond to treatment after they relapse was only 4 days, and complete response was seen in as little as 5 days, meaning that these patients were able to be treated very easily, very quickly for their relapse of ITP after vaccination. And indeed, out of the data we have available, 7 out of 7 patients with a prior history of ITP who had unstable platelet counts after vaccination were free from relapse at 3 months. And this little graph just shows you how these patients had relatively decent platelet counts going into vaccination. Certainly they crashed after vaccination, but well within 1 month their platelets were pretty much back to where they were before. So finally, I'd just like to pay tribute to my colleagues Robert Bird, Eileen, Ashwini, Anoop, Chiwi, Isaac and Danny, and in particular Robert, whose idea it was to bring us together to write these guidelines and to publish them for the benefit of our patients with ITP.